people put validity. Validity has nothing to do with how well the measures. I feel like you had a 50-50 shot on that one. It was either inter-rater or intra-rater. We'll talk more. Anybody that wants to come by.
Yeah. I put intern. Yeah.
Okay. So week 4, therapeutic ultrasounds, and one we're just going to kind of skim through really quick today. Just talk about a couple of things that are important for what we're using it in lab for. But also under week 4, down at the bottom, you have the ultrasound abstract assignment. Is that available? Can you open that? Or is that not?
It's available.
I just wanted to open it up to show you, like, literally all we're going to do is go find an article that looks at using ultrasound to treat something. It can be carpal tunnel, it can be peroneal tendonitis, some elbow tendonitis, whatever you can find. Just make sure that it's within like the past 10 years. So I don't want to find something from 20 years ago. Science has changed and the research is, so we want to find newer research within the last 10 years. Find you an article, and then we're going to write an abstract about it. So when you look at research articles, there's usually an abstract at the top that basically generalizes everything for you, and then it goes through the whole research methods, how they did everything. So for yours, in your abstract, I want to have a background and a purpose. So what are we studying? What's the question that they're asking, right? The ask of the research, right? It should include the methods, so discuss the methods that they used, talk about if there was any bias, talk about their sampling collection, talk about their measures, the tools they used, validity, reliability, all of that. That's where we're getting at the praise. And then you're going to put in what the results of the findings, results of the study, and then the conclusion. So discuss what information can you gain and use clinically, what can we do to apply that information, and discuss whether or not you feel it's a well or not well designed study. So we're going to assess that information. So then you should just write up about 1 page, double spaced, no more than 2 pages. We don't need at least a page, no more than 2. It doesn't have to be a full page. As long as you include all that information, you're going to be solid. That should be plenty enough information for you to talk about, probably cover 2 pages. And then I want to make sure that you have a reference page and cite the article that you're using in the proper APA format, which you can find in that library tools that showed you guys at first day. So, and that's due like October 3rd. So I just wanted to kind of give you a heads up. I think it opens up next week, but I can open it now if you want me to. And we have until October 3rd.
It's open. It's open. Yeah,
Turn that in. You just upload it right there. Underneath that is the hot and cold competency submissions. A few people have already turned their SOAP notes in. That's where you put in your SOAP notes for the stuff that we did this week. Throw your SOAP note in there. I'll grade it, and then I'll give you some feedback on how you did with the competency and how you did with your SOAP note. So you get a chance to see how those are going to be graded, and then let's just run through some ultrasound. Any questions on any of that so far? Easy peasy. Again, I'm not doing like a full lecture. I just want to hit some highlights.
Sorry, if we know we forgot to do something during the mock practical week, in our sub note, do you want us to put like we forgot to do it, but if we did do it, it would go there? Or if we forgot to do it, just don't
put,
put it?
just do your SOAP note like you were 100% perfect. Just the SOAP note's really just to get practice. I'm not taking off any points for SOAP note stuff right now. Like after you've had the class, we've learned how to do SOAP notes a little bit, and we can start maybe. But I'm not gonna. I'll lump that in with like termination of treatment. So cleaning up your area, doing all of that, writing the SOAP notes. So the soap note's not going to knock you down
Okay.
anyway on regular practicals, which you're learning. So just put in soap note. That's just for you to practice. All right. Ultrasound's used as an adjunct therapy for any acute chronic diseases, mostly bursitis, tendonitis is the big things we're going to use it for. You can also use muscle spasms, contractures to help with pain reduction, helps with wound healing. It has thermal and non-thermal effects. What does it have to be to have a thermal effect? What cycle? What duty cycle? Continuous. And then pulsed is not thermal. So it's thought to increase cellular metabolic activity, blood flow, enhance collagen extensibility, break down calcium deposits, and produce an analgesic effect. It can also be used to deliver medications. Typically, hydrocortisone, dexamethasone is the most common one, but you would put that medication on the area. You put your gel on the ultrasound head, and then you would use ultrasound over the medication, and the sound waves are thought to help push that medication deeper into the muscles and tendons and all of that stuff. So ultrasound waves are most easily absorbed by bone, followed by cartilage, tendon, skin. 100% thermal. Non-thermal creates the vibration in response to the waves, and that includes cavitation, which is microscopic gas bubbles that stimulate the cell membrane, and then acoustic streaming, which is movements of the fluid through the compression of the sound waves. So that's kind of where we get the tissue healing part of it, is because of those things. The less time in the duty cycle, the less the thermal effects. Is conversion therapy by taking sound waves between 85 kilohertz and 3 megahertz, delivered at intensities between 1 watts per centimeter square and 3 watts per centimeter square. The ultrasound applicator, like inside the sound head, we have the crystal or the transducer that takes that electrical energy and turns it into sound waves, which then creates the vibrations and turns into heat. So the size of the transducer heads go from 1 centimeter squared to 10 centimeters squared, with the most common being 5 centimeters squared. Transducer size should be selected relative to the area that you're using. So if you're working on a wrist, you want to try to find 1 centimeter squared if you can, whereas shoulders, legs, things like that, we use 5 centimeters squared. The ERA is the effective radiation area, and that's the area of the faceplate, so the crystal size inside the ultrasound head. Continuous, that's thermal. So uneven intensities produce a high level, and I think there's a better slide that talks about this in a minute. But you have some hot spots inside that crystal because crystals aren't perfectly shaped, they're pointy and jagged. So there's spots where you're going to get a hot spot, which is your peak intensity from the beam, and then you have an average intensity. And that's typically what we use to measure. But the beam non-uniformity ratio is the difference between that spatial and that high intensity. So there's a better picture in a minute. We'll talk more about it. But the BNR should be between 2 to 1 and 6 to 1. Most of them are usually 5 or 6 to 1, typically. We'll talk more about that in a second. These slides aren't arranged great. But near pulse ultrasound, on off. 20% duty cycle will have an on time of 2 milliseconds, off time of 8, and then that just changes and goes up. And then between 51 and 99 produces less acoustic energy, which means less heat. Treatment considerations: absorption in the highest tissues with collagen and protein content, so muscles, tendons, ligaments, and capsules. The scattering of sound waves from reflection and refraction produce the friction, and then that sound wave has to overcome that to penetrate through the tissues. Typically it goes 3 to 5 centimeters. The depth of penetration is influenced by the frequency, so that 3 megahertz versus 1 megahertz, and that's because of the scatter, and there's a better picture of that too. 1 megahertz will cause increased heat production in deeper layers, while the 3 megahertz is more superficial layers. There's contraindications and stuff, remember that. So anytime you use ultrasound, you have to use the coupling agent, because you have to have a medium for that sound wave to pass through, because when it hits the air, it just kind of disperses, and that sound, the gel keeps it concentrated. And then the intensity, again, the ERA is what we're talking about, that effective radiation area. It's always going to be smaller because it fits inside the transducer, and it's on all of them. Those of you that have had labs, you'll see there's those stickers on the cords where it'll tell you it's 5 centimeters squared or whatever it is. Here's a better picture of that VNR. So we have that ratio from the peak power to that overall average power, and that's where that picture, you can see how funky it is. So we got that one spot where you're getting the highest intensity compared to all the spots around it sending out the sound waves. And that's why it's so important to keep it moving. Because if you have that higher intensity spot constantly over one spot, it can lead to some issues. So we talk about cavitation. It's part of what helps with the pulsed ultrasound. It creates that healing through cavitation. So the gas filled bubbles expand and compress. Stable cavitation means those bubbles don't burst. Unstable means that due to all the cycles and constant vibrations, you get things bursting inside the body. So the depth of penetration is roughly a burst in frequency, meaning 3 megahertz is superficial, 1 megahertz is deeper. So 3 megahertz, and I think I kind of drew this out in the lab for a couple people so far. You're getting more vibrations per second, so you're getting more energy, but the energy isn't available to the tissues. It gets broken up before it gets there. So as this is going into the tissues, those waves are hitting more frequently, so it's getting dispersed at that superficial layer where these longer waves have time to penetrate deeper. That's kind of what the 3 megahertz and 1 megahertz look like. Other terms you might hear for frequency are rate, cycles per second. Megahertz is the common way we use it. We just talked about that. So the wave transmission travels through the medium in 3 modes. You get longitudinal, transverse, and standing. Longitudinal just means it's going in the direction that you're sending. So the particles are compressed and decompressed in the direction the wave travels, just like in human tissues. Transverse, the particles move at right angles. So that can happen a lot of times if you lift the ultrasound head a little bit, as it kind of goes this way into the skin, it reflects a little and goes 90 degrees up. And if that pressure reaches the bone, so after you go over the bone and you send that transverse thing in there, it travels down the periosteum, which can cause some pain and it's not comfortable. And then standing, the source just stationary on top of the area, and we don't want to use that. Again, you want to keep it moving so that you don't accidentally run into any problems. Duty cycle refers to the percentage of time that it's on. So there's some calculations here we'll talk about next time. Continuous ultrasound again is for heat. Common duty cycles, 150, 20, and I think there's a 10 on most of the machines. Typically, you want 5 minutes per 2 by 2 inch area. Average treatment time is 8 to 10 minutes. If it's less than 3, it's not going to do anything. And we can go over 10 minutes if we need to for chronic conditions, but usually at a lower intensity. Number of treatments depends on your objectives, the level of acuity, the patient's response, and then using non-thermal effects, you usually see a positive response in about 3 sessions. Thermal effects, you want to use it 2 to 3 times a week. But you don't want to go over 14 because more than 14 treatments shows a reduce in red and white blood cell counts. The depth, 1 megahertz, 3 megahertz. The intensity is how we measure it. So if you're doing 1 megahertz, you can do that intensity between 0.5 to 2 watts per centimeter squared. Scar tissue, tendons, and ligaments demonstrate the highest absorption. bone and tendinous attachments of the skeletal muscle, cartilage, and peripheral nerves absorb the least. So when you're doing a treatment, you ask yourself, are we doing something superficial, deep, or something subacute? So if it's superficial, we're going to use the 3 megahertz, which is roughly a half an inch to 1.5. And then the deep goes 1.5 to 2, roughly, and that's 1 megahertz. And then you want to know how acute the condition is. The more acute it is, the lower the duty factor you want to use. So if it's super, super acute, muscle strain or something, we probably want 10, 20%. But if something that's like a week or 2 old, we could probably go up to a higher duty. So just talking about absorption versus penetration. Absorb means to take something in, where penetrate means to enter into. So the more dense the tissue, the greater the resistance levels are. Sound travels easily through air, but poorly through a brick. Human tissues are complex with different layers, so each type absorbs ultrasound differently. So if you have the gluteus maximus, which is roughly 4 centimeters deep, when you're doing ultrasound on that area, 70% of the energy is going to get absorbed before it gets anywhere through that muscle. And then with reduction of amplitude, which is attenuation, it's increased by a moist hot pack. So there's less penetration of ultrasound after using a moist hot pack. Reflection versus refraction. Sound waves can be reflected off of barriers, and that's kind of what happens as we do ultrasound. They redirect the beam away from the reflecting surface. So as we're doing ultrasound, we got skin, we got muscles, we got ligaments, we got all kinds of things that kind of reflect, whereas refraction means it's entering at an angle. So it's transmitted across the boundary and it's sent sideways. There's a picture of refraction here in a second. So when you're getting into refraction, the beam's coming in and then refracts off instead of absorbing through the tissues. You get these really strong peaks of intensity followed by lows in the returning power. So you're getting like a double dose of those sound waves, which could potentially be harmful. Again, why it's so important to keep the ultrasound head moving. Photophoresis, we're not going to talk about today because we're not doing that. Underwater ultrasound, instead of using the ultrasound gel and putting it directly on the patient's skin, you put them in a bucket of water. You're going to hold the ultrasound head around an inch away from the body. You're not actually going to touch it. The sound wave travels through the water into that area that you're treating. You use 1 megahertz for any underwater. You don't want any air bubbles. So don't jerk it around, move it slow and methodically. And then again, different megahertz for different depths of tissue. Direct contact is how we're going to do it rather than underwater, which is the immersion method. Treating wounds, you would use a hydrogel disc, which is a disc that just covers the wound when you do the ultrasound on top of the disc. And then stationary sound head is something that we're never going to do because that literally means you're just holding it on one spot and we can have tissue damage because of the hot spots. Subacute, these are like measurements for how you would figure out your treatment time. I'm not going to put any of this on the test. If there's already some test questions there, I'm going to take these off because typically you're going to have to at least do 8 minutes regardless, and you don't really want to do more than 10 unless it's a chronic condition, and then you just do a lower intensity. But these are here. This is how they measure specific treatment times. And then we already talked about most of that. We'll cover it more later. Using ultrasound and soft tissue mobilization will increase cardiac output and metabolic rate. So it can be effective given every other day, and it should have positive benefits by the 3rd or 4th application. If not, we're going to stop and try to do something else. Maximum number of 12 to 15, because what happens after 14? Correct, reduction of red and white blood cells. Good job. Okay, I know we ran through that really fast, but we're going to do it in the lab. A couple groups already have. The other group's gonna do it today. So I wanted to kind of let you open that up, get a look at it, talk about it, be thinking about questions during whoever has lab today or between next week. Because when we go to lab next week, we're gonna do more ultrasound. We'll make up some scenarios, and you can decide whether you need to use pulse or continuous, things like that. We can work on each other, work on the different machines. You've got the information, so if you have questions about the slides, we can ask during the lab. Next week, while we're doing ultrasound 2, we'll probably start doing a little bit of traction, even though that's not till the next week. But I want you guys to have more hands-on time. And the way that the class was set up previously is like you learn ultrasound, we do ultrasound, you learn traction, we do traction, and then the next week you have your practical. And I want you to have more time to get hands-on and run through scenarios and not just be like boom, boom, boom. So we'll do mostly ultrasound, maybe talk about traction, maybe do one example, grab somebody and I'll put them through some cervical, lumbar, whatever. That way we can at least see it, and then we'll have the lecture, and then we can do traction for the whole lab. And then the week after that, we'll be the practical for either ultrasound or traction. Okay, that was really fast. But again, I just wanted to plant the seed of ultrasound today. We'll go through more next week. Anybody have any questions about this stuff? You got a week to come up with questions. All right, that's it. That's all I got.